Bismillahir Rahmanir Rahim. This is a very common topic which our examiners like to teach us, and as well as when they want to tease us, they also use this topic. So, people basically it is an aperture which constricts and dilates, and its constriction and dilatation permits the light required to be transmitted from the retina to the brain. So this is the first opening, and what passes through pupil, light passes through the pupil. Cornea reflects the light, refracts the light, and it goes to the retina through pupil. The second thing which passes through the pupil is aqueous humor. This aqueous humor is produced by the ciliary body in the posterior chamber. This aqueous humor nourishes the lens, crystalline lens of the eye, and then this aqueous humor passes from the pupil into the anterior chamber and then drains through the trabecular meshwork. So this is the structure which we see from the front. Two pictures here. It is constricted and it is mid dilated pupil. Both two muscles, the constrictor pupillae and the dilator pupillae. So this is the constrictor pupillae, and this, the parasympathetic control occurs here in the constrictor pupil, and the sympathetically controlled radial muscle. Constriction of constrictor pupillae constricts the pupil, and constriction of these radial muscles, not dilatation, constriction of these radial muscles dilates the pupil. So this is the parasympathetic one and this is the sympathetic one. So whenever there is disturbance to the sympathetic area, the pupil usually constricts. So the learning objective of today's topic is RAPD. Physicians, neurophysicians and ophthalmologists usually use this term, relative afferent pupillary defect. So I have the repetition of some slides just to have a revision of our previous knowledge. So we can compare both the pupils. This is a slide. If we learn this slide in this lecture, I think our objective is completed. When we shine light to the left eye, pupil of the left eye, this also constricts. The right one also constricts. We all know this is called consensual light reflex. However, here you see we are shining light to the right eye, but the left one is not constricting. Both of them are dilated. So this is the problem. Here is the problem, that the right eye is affected. When we again come to the left eye, both the pupils are again dilated. So this is the RAPD. We say OD is right eye and OS is left eye. So this eye is problematic. The right eye has problem that it is not taking the impulses, the rods and cones are not taking the light, and the optic, there is some problem with the optic nerve, with the retina, and with the optic tract. See here, where is the problem in this picture? Again, the problem is in the right eye. So this is just anatomy of the same thing. This is governed by the parasympathetic and this is the sympathetic one. Which one is the pupillary area? This one, which we discussed. This aqueous humor produced here and comes through the pupil and goes to this angle, this corneoscleral angle, this one, and drains through the trabecular meshwork. So here we can have an overview of the eye anatomy as well. So this is the cornea, this is the anterior chamber, this is the iris, this is the pupil transected, and this is the posterior chamber. The posterior chamber of the eye is very small. The area between this lens and this iris is called posterior chamber. So usually people, so, and the area behind this lens is posterior segment. So we divide eye into anterior segment and posterior segment. The lens and anterior to the lens is the anterior segment. This one, this square shows the anterior segment, and the posterior segment behind this lens is posterior segment. It is not posterior chamber. The posterior chamber is between the lens and this iris, the small slit area. So again the same. Where is the problem here? This one is good eye and this one is diseased eye. It is neither it constricts and the consensual is also absent. So pilocarpine and atropine, one is agonist and the other is antagonist. What will happen to people with pilocarpine? It will constrict because it will stimulate the parasympathetic fibers and which will constrict the constrictor pupillae. So pilocarpine will constrict the pupil. And what will atropine do? It will dilate because it will inhibit the parasympathetic stimulation to the constrictor pupil. Usually we do not use atropine to dilate the pupil except in children because the duration of action is about 2 weeks. For 2 weeks the pupil will be dilated, there will be blurring of vision, so we do not dilate with atropine. We use tropicamide. Tropicamide has a duration of action of 4 to 5 hours. So after 5 hours the pupillary size becomes normal. So again here see, sympathetic nerve it dilates, parasympathetic constricts. The same anatomy which we all know. Here the decussation occurs and from this area the pupillary light reflex has not, so when the occipital lobe is, this lobe is affected by trauma or something else, the pupillary reflex will remain intact because see here, this is the pupillary light reflex. from the iris to the ciliary ganglion, through the third nerve to the midbrain. So why this consensual light reflex is there? When we shine light to one eye, the other eye also constricts, if provided the optic nerve is intact. So these are the fibers. These are the fibers. From this right eye, these fibers go to the pretectal nucleus of the left side. So these are the fibers which are responsible for the consensual light reflex. When we shine left eye, right eye will also constrict. Meiosis. By looking to the pupil, we just have a light onto the eye. You can diagnose many things. When a red eye with constricted pupil, it is usually uveitis. Constricted pupil with red eye. Constricted pupil with no red eye with no effect to the pupil, usually conjunctivitis. And constricted pupil, dilated pupil with red eye is glaucoma. So by just shining a torch light to the eye, we can diagnose the whole chapter. In uveitis, it is the rule, unless there is posterior synecdoche. See here, dilated pupil, glaucoma. So this is the pupil size. In trauma, the optic nerve, being a portion of central nervous system, is really a tract and not a peripheral nerve. The 1.2 million axons that emanate from the retinal ganglion cells carry the name optic nerve until they partially decussate at the optic chiasm. So again, it has four portions. The intraocular portion, which we do in fundoscopy, about 1 mm, and this 25 milliliter is intraorbital, and this is intra 9 mm is intracanalicular, and here it is intracranial portion of the optic nerve. Again, this is the repetition of the same slide. The clinician can establish any asymmetrical damage between two eyes by simple comparison of how well the pupil contracts to a standard light shown into one eye compared with the same light shown into the other eye. Observation of the pupil movement in response to alternating light back and forth between the two eyes is the basis for the alternating light test or swinging flash test, used to assess the relative afferent pupillary defect. So swinging flash light reflex, it would be better if we had a patient again. See here, this is the good eye. So, an old clinical rule of thumb states that if the pupillary light direction is spared, the third cranial nerve palsy probably does not result from compression or injury, but more likely from small vessel disease such as diabetes and hypertension. So this was about the RAPD, and we use swinging light reflect test to see whether the RAPD is positive in the right eye, means the right eye has some problem. If RAPD is positive in left eye, means the left eye has some problem. See here, normally when we shine light, it should constrict both eyes. But when we take the light from this better from the better eye to the affected eye, both dilate. Both the pupils will dilate, and we can see that there is some abnormality. And if one eye has cataract, the pupillary light reflex will be normal, because the neurons are intact, optic nerve is intact, sympathetic, parasympathetic is intact. So this was the message, that we should have at least one torch to see the RAPD. And it is usually written in the prescriptions of ophthalmologists and neurologists that our right RAPD is positive. Once RAPD is positive, then the this is the irreparable loss of the vision. This is leukocoria. Again, as it was topic of people, so leukocoria, congenital cataract. Same. What is this? Retinoblastoma. Usually in retinoblastoma, when we shine light with the ophthalmoscope, we see such a picture, that the cornea is okay, the lens is okay, the anterior chamber is okay, but there is wide pupillary reflex that comes from the retina, not from the lens. So this is retinoblastoma. This is a congenital defect of iris coloboma. Sometimes there is no iris, congenitally, absence of iris and iridia. What is this? In end-stage diabetic disease, due to ischemia of the retina, we can see some new vessels here on the iris. This is usually gone eye due to neovascular glaucoma. So what it could be? It is a picture of metastasis from the breast cancer. ये क्या हो सकता है? I think it is the last slide. जी, this is the trauma. This is called iridodialysis. Uh, the iris is detached from the ciliary body due to trauma. This is a picture of hyphema, blood in the anterior chamber. Again, here the pupil is sluggish, mid-dilated due to trauma. Uveitis, a picture of uveitis. Inflammation of the uvea, iritis, iridocyclitis. Here we see the iris, we call it posterior synecdoche. When the iris is attached to the lens, it is posterior synecdoche. When the iris is attached to the cornea anteriorly, we call it anterior synecdoche. So this is posterior synecdoche. But this juvenile rheumatoid arthritis, we do not see these synecdoches. These are in that uveitis. Usually the eye is quiet, but we see the cells in the anterior chamber. This is again trauma, because this is a picture of traumatic cataract, and it is the rupture of sphincter pupillae muscle. But in such a eye, if the optic nerve is intact, when we shine light to this uh, pupil, what would happen? Optic nerve is intact, and here it is not constricting. This pupil is not constricting because the constrictor pupillae is damaged, but the other eye would constrict, and it will show that the optic nerve of this eye is intact. It is taking impulses, so the efferent pathway of this is okay. So any questions?
Somebody present with JRA,
Yes.
how many time it takes to get eye disease like rhinosinusitis and something?
So all GRA patients may not have this.
May not have
Yes. Uh, uveitis.
uveitis or rhinosinusitis. JRA.
So the word uvea, what is uvea? The iris, ciliary body, and choroid. All these make uvea. So when there is inflammation of only iris, it is iris. When